Hi, everybody. You're about to hear a lecture and a talk from Dr. Sharon Laing from University of Washington in Tacoma. She has her PhD in developmental psychology from Howard University. She has a master's degree in developmental psychology from Howard University, and she has her doctorate from McMaster University in psychology. And she is someone who both is a psychologist, but she's doing work in nursing, and she works across disciplines. So healthcare, psychology, all of which is really under the same banner. And she's moving across methodology. She's a qualitative researcher, she's a quantitative researcher, and she's doing important work. I invited her to this, because she's an outstanding teacher and mentor. She's won many awards for her work, but she's doing important work that's relevant to 2020. She's doing work on race, on health, the impact on stress, and she's talking about our iPhone devices and the ways in which we can monitor our own health. And ultimately, she's talking about truth, reconciliation, and repair in our communities. So I hope you enjoy her talk and her lecture. Look her up because she's doing important work that has applications to all of us, but in particular, underserved communities.
My name is Sharon Laing, and I'm an assistant professor in the School of Nursing and Healthcare Leadership at the University of Washington in Tacoma. I want to first welcome you to a new and exciting and somewhat different year for any student at this institution. I'm so delighted to be with you today and to share with you a little bit about me, my research and scholarship, the role that 2020 has and is playing in how I now conceptualize and will deliver my scholarship, and my thoughts about how we will and can move forward. The approach that I will be taking today, as I reflect on the year 2020, is to interrogate the consequential health toll of COVID-19 on communities of color, particularly African American communities. My objective is to lead a discussion on the fact that racism is a leading factor that explains the disproportional health outcomes for Black and Brown communities in the United States, and especially during the COVID-19 pandemic. Please join me in this journey. So what I present to you is the title of this talk today, Dual Pandemics, COVID-19 and Racism, Finding Pathways to Heal and Repair. So we'll begin this discussion by reviewing health disparities in the United States. Now, residents of impoverished neighborhoods have a higher mortality rate, death rate, and reduced life expectancy. Residents of impoverished neighborhoods report more chronic health problems, including heart disease, diabetes, some cancers, and obesity. Racial and ethnic groups are more likely to experience poverty. Now, when we look at the high morbidity or disease and mortality, death rates, these outcomes can be explained not by any biological differences between individuals of different racial groups. Genotypically, there are no substantial differences between whites, Blacks, and other races. Rather, these health differences can be explained by social, economic, and environmental factors. We call this phenomenon the social determinants of health. That is, when we look at the image to the far right, we see a number of different social factors that will predict who will live and who will die. For instance, let's begin by looking at availability of social resources. Availability of social resources speak to availability of transportation, availability of childcare services, availability of banking services, availability of community health services. As we traverse and we visit a number of low-income communities, you may see disproportionately lower numbers of these type of social services available to the communities of the individuals of these communities. When we move down to look at quality of education, once again, we see disparities by race in the type of education and the quality of education available to students of lower income communities. You can see differences in the physical structure of the building, whether you may have peeling paints or broken down buildings, whether you may have childcare facilities like playgrounds for children to play in, whether you may have paved walkway for the children to walk to and from school, sufficient lighting in that area. All of these factors will determine the quality of the education, including the availability of quality books and resources, technical resources and technology for the students to access. When we look to the right of the education quality, the other social determinant of health factor that we see here is access to health care. Individuals who are disproportionately presented at the lower income ladder may not have the best healthcare access that individuals at the highest end of that ladder will have access to. They may not have access to the jobs that will allow them the benefits, the healthcare benefits, so that they can go and get diagnostic testing when needed, so that they can get access to specialists where needed, so that they can visit the physician to address a particular healthcare need. When we look to the right of quality of healthcare, we see another social determinant of health factor, and that is housing and food. Food speak to the quality of food that might be available to individuals living in low resource communities. Do they have adequate shopping facilities that have fresh fruits and fresh vegetables? Or do we see a preponderance of mini marts that present with more processed foods for individuals living in these communities? What about the housing of individuals of low resource communities, the quality of the housing, the number of single family homes that might be available versus the number of multi-unit family dwelling? What is the nature of that environment? Are there sufficient green spaces available for individuals to go to parks and to be involved in recreational activity? And then finally, as we move up, we see again other factors that determine health outcome, which include wealth distribution, as well as the working environment. And so where the person lives, where they work, and where they play are all factors that will determine the viability of individuals. All of these factors, therefore, will explain how people will fare in their health and well-being. We must find a way to target the social determinant of health factors so that we do not continue to see differences among groups of individuals in our communities. So then, what is my scholarship and how does it relate to social determinants of health factors? Well, my scholarship tackles one specific factor, and that is access to healthcare. I'm interested in looking at how technology, particularly mobile health technology, smartphones, electronic sensors, mobile health apps, how can these technology include individuals into our healthcare system who historically have been disenfranchised or who are not getting the care that they need? It's simple, really. Smartphones are ubiquitous. They're all over the place. 81% of Americans own a smartphone. Now, reliance on smartphones for online access is quite common, and it's common among specific demographic groups. It's common among young people, it's common among communities of color, and it's common among lower income Americans. This now presents a wonderful opportunity to address healthcare needs using a very simple element, and that is the availability of smartphones. So I'd like to just speak to this particular image. This image speaks to how mobile health technology can bring individuals into the healthcare system and empower them to engage in self-monitoring, self-diagnosing, and therefore acting in order to maintain positive health and well-being. To the left of this image, you see the opportunity to monitor a number of biological and physiological activity. And so electronic sensors, which are these small devices that can pick up very minute and very sensitive activity in the body, can monitor various changes that will allow the individual to track how they're doing, can monitor electromyographic activity, muscle activity, can monitor brain activity, and can monitor heart activity. That information that is being monitored is then sent to a central processing unit in the smartphone that aggregates that information and then presents a readout for the user to see how they're doing on a number of health indices. That information can also be sent outside through the cloud and to a healthcare provider, which is to your far right here on this image, who can read that information and provide direction to the patient remotely so that behavior change can happen. And then the person can be engaged in positive health monitoring and positive behavior change. What a fascinating phenomenon. Here you have the potential to engage communities who typically and historically disengage from the healthcare system and allow them to be in control of their healthcare delivery by monitoring changes in their body physiology and then to make changes in their behaviors in order to support positive health and well-being. So I conducted research with colleagues to understand, now that we know that we have a tool that everyone uses, that we can use to engage a segment of our population in their healthcare management. I wanted to understand the extent to which low-resource communities are using this tool for that very purpose, to support their health and well-being. And so we surveyed low-resource communities from two different regions, the East Coast in Washington, D.C., and West Coast here in Washington State. And we wanted to know the extent to which they use their smartphones to obtain health information, the extent to which they're willing to use mobile apps for tracking and self-care monitoring. And here presented on this slide is a few of our findings. We found that significant majorities of these patients, more than 3/4, are using their smartphones to obtain health information and engage in self-care. We found that less than 50% of low-resource communities are using mobile health apps for preventive care, including step monitoring, caloric intake monitoring, blood pressure monitoring. We found that more than 50% of this community use medical application for medical support, including prescription refills, medication reminders, and perhaps finding a pharmacy. We still, however, see some sociodemographic barriers to engagement in healthcare using this device. We see that the lowest income level groups are less likely to engage in using mobile technology to support self-care. We also see that individuals who are part-time employees that do not have full employment are also less likely to engage in the technology. What this tells us is that user-centered design strategies must consider how to tailor mobile apps to meet the needs of low-income communities. That is, how do they address issue around digital literacy or health literacy or language barriers? And so while we know now that low-resource communities are willing to use this device to support their health and wellness, we must make it easy for them to use these devices for their health and wellness. 2020 laid bare the health inequities that exist in this country. What happened in 2020? Well, a virus none of us could have imagined descended on us all to begin this new decade in the most ominous and pernicious fashion. When we first heard about this virus, we thought that we, in the United States, were removed from this problem. It is a problem for others, but not for us. We are, however, an interconnected world. So, as of October 2nd, 2020, there are 34 million confirmed COVID-19 cases in the world, 1 million fatalities around the globe, 7 million confirmed cases in the United States, 210,000 confirmed deaths in the United States. These are truly challenging times. We also have social ills that are now magnified: economic and social disparities, health disparities, social injustices. All are running amok in our communities. The one challenge that has impacted me personally most profoundly is trying to assess the two most pressing pandemics of 2020, racism and COVID-19. So the question we must ask is, who is most likely to die from COVID-19? Now, this data is a data from the United States Facts Department, and it's the US coronavirus cases and deaths that are tracked daily by state and county. And so this image that we're looking at here presents the 7-day moving average of cases per 100,000 population in the United States. Now, it presents this information in quadrants by different regions within the US. The red line that you're seeing here is the average for white Americans, white non-Hispanic Americans. And although we see, obviously, for all of these quadrants, the cases have been rising since the start of March until into September, we see that the numbers for white Americans is substantially lower than the numbers for all other counties. And so these are white Americans, white American counties. And so we see a substantial difference. As we move to Latinx communities, and so I'm just circling the item up top, Latinx communities are represented now by the red or bronze line, and the blue line represents all other communities. Here, from this diagram, you can see a substantial difference between the number of, the average number of cases that are diagnosed among the Latinx community versus individuals in other communities. And so we see a substantial rise, certainly early in the pandemic, among Latinx communities compared to other communities. As we move on to African Americans, the Black communities in the US, we see the same trends as we have seen with the Latinx communities. The African American communities represent the bronze line, once again, the red line. And we see once again that their numbers, whether we're taking these figures from the Midwest, the Northwest, the South, or the West, for the most part, the average number of cases per 100,000 for African American counties are higher than for other counties. And so this diagram, whether we're looking at the Latinx community or the Black community, we see who will die from COVID-19. This virus is affecting specific groups of people. This figure here shows the number of cases and deaths by county since the first US case was detected. And so this was taken from August 2020, August 16. And so here, this is telling us that 45% of cases and 51% of deaths are in 22% of counties that are disproportionately Black. And here, this image shows us the absolute devastation on the Black community by the COVID-19 virus. So let's talk a little bit more about social determinants of health, Black Americans, and COVID-19. So again, we'll refresh ourselves on what these factors are. So we mentioned the fact that social determinants of health is speaking about these social factors that determine health outcomes for different groups of people, whether it be social, the availability of social services, the quality of the education that someone has, the quality of healthcare, the quality of housing and food supplies, the wealth of that individual. These are social factors that will determine health and wellness for communities based on access to these social entities. Millett and colleagues did an analysis of the differential impacts of COVID-19 on Black communities, and this was recently published in the Annals of Epidemiology. And this image here presents the demographics of mostly Black communities versus all other communities, and these are counties. And so for the mostly Black counties, these were the counties were defined as areas where there were at least 13% Black Americans occupying that space. For all other counties, the numbers were less than 13%. So I'd like to call your attention to the bottom two rows of this table. We see that for the second to last row, the number of cases that were diagnosed and per 100,000. And so if we look to the far left side, the second column, we see that 22 people per 100,000 were diagnosed as far as mostly Black communities or counties. To the right of this column, the very last column, we see only 5 individuals per 100,000 who were diagnosed with COVID-19. As we look further top to look at some of the social factors that were present in these communities, we see if we look at the mostly Black counties where we had such a higher diagnosis rate, as well as a higher death count, we see that the majority of individuals, Black individuals, were uninsured compared to those in the other counties. We see that unemployment rate was also higher for the mostly Black counties where we had a higher diagnosis rate and a higher death rate. Unemployment rate was also higher. We also see that household occupancy, as defined as about less than one person per room, was also higher for mostly Black counties. And this speaks to the issue of social distancing. And so we're seeing here from this table that social distancing is an issue and was an issue for mostly Black counties. When we look at particulate matter, air toxins, we see that there were greater air pollution in the mostly Black counties, 7.7 relative to other counties, where the count was 5.6. Finally, the measure of social distancing, the score, we see that for a higher score for social distancing, this indicates worse, a less likelihood of being able to social distance. We see that the mostly Black counties fared worse. So this table nicely encapsulates what is happening across Black counties versus counties that were not predominantly Black in terms of the social determinants of health factors, unemployment, health insurance, as well as the possibility to physically distance when we look at population density, household occupancy, and the presence of environmental toxins like particulate matter. Millett and colleagues presented some very nice encapsulations of what their findings actually indicated. And so some final analysis from the study were as follows. They found that 90% of mostly Black counties reported a COVID-19 case versus only 81% of other counties reporting a COVID-19 case. They found that almost half of mostly Black counties reported a COVID-19 related death versus only 28% for all other counties. They also noted that counties with higher proportions of Black people had higher prevalence of comorbidities. And what they're speaking here is the presence of multiple health conditions: diabetes, hypertension, obesity, heart disease. They found that counties with higher proportions of Black people had greater air pollution. In looking again at the differential impact of COVID-19 on Black communities, when we're looking at specific health, social determinant of health factor, that is health insurance, Millett and colleague also made some observation. They found that a fraction of the COVID-19 diagnosis due to lack of insurance, health insurance, was 3.3% for counties with less than 13% of their residents being Black, but was 4.2% for counties with greater than 13% Black rates. Meaning that the diagnosis of COVID-19 that was attributed to not having insurance was higher for Black counties than it was for non-Black counties. And here we see a social determinant of health factor, access to health care, contributing to poor health outcome, that is a diagnosis of COVID-19 for African American communities. So, social conditions, structural racism, and other factors elevate the risk for COVID-19 diagnosis and deaths in Black communities. Residential segregation can create concentrated neighborhoods where residents are predominantly poor, predominantly Black and brown, or of immigrant status, or social spaces with concentrated social problems. Residents are likely to experience greater exposure to stressful environments while having fewer resources to cope with these exposures. Poor neighborhoods are linked to low health and social services, problems with access and timely services, increased health hazards from the physical environment like air pollution, as we saw with the Millett study, lead, dust, dirt, and smog, substandard housing and schools, reduced green space, reduced fresh fruits and vegetables, and reduced social connectedness. The concentration of families within higher risk neighborhoods increase the individual burdens, especially when there is a catastrophe like COVID-19. Racism must be emphasized and racism must be dismantled. Personal racism is a source of stress with possible chronic and acute dimensions. So what you have here in front of you is an image that presents the various impacts that we can see of stress on the human body. So here on the left, you can see the number of different systems, the number of different structures that are impacted by stress or the experience of chronic stress. What is pointed out here is the impact of stress on the immune system. So perceived stress, that is the experience, the subjective experience of stress, is related to reduced immune function. And a reduction in immune function is associated with, for instance, lower helper T cell activity or reduced natural killer cell activity. And so if our body is no longer responding or trying to protect us from the onslaught of foreign invaders, this will lead then to increased susceptibility for various health issues. What this means is that chronic and sustained stress really devastate our body system and allow us to then be invaded by foreign substances and then compromise our system. This image is a presentation of the entire body system, but again, looking at the impact of stress on cardiovascular system. So in this case, what is the impact of sustained chronic stress on the sympathetic nervous system? Chronic perception of racism over time, racism being a form of stressor, coupled with a passive coping mechanism, that is, an inability to use resources to address the discrimination, can lead to increases in prolonged activation of the sympathetic nervous system function, Now, this can result in an increase in resting systolic blood pressure levels and then prones the individual to cardiovascular diseases. Research has shown that chronic stress-induced sympathetic activation can, in fact, lead to hypertension. So we can see, it's clear that we are witnessing the devastation in so many communities of color, communities likely to experience the stress of racism. And we can understand why these communities are experiencing some of the adverse health effects that they have been experiencing. Racism is the deciding factor for the health outcome for a number of these communities. Racism decides where some people will live. Racism will decide access to care. Racism can decide who can socially distance in the middle of a pandemic because they lack the resources to be in communities that permit social distancing. It will decide who will have poor air quality, thus deciding and who will have an increased risk of compromised respiratory function. Racism will decide who will have sufficient health insurance to receive quality health care, who will present with higher incidences of chronic diseases such as heart problems, thereby increasing their risk of death from a deadly pandemic. And racism will decide who will present with compromised immune functioning, which is another factor that will increase the risk of death from the pandemic. So, a few questions that I'd like to think about and share with you. The first question that was posed of me was, how has the pandemic impacted me? As a scholar, I'm compelled to use my voice and knowledge to enlighten and inform institutions of the fact that we must act now to implement anti-racist approaches in order to save lives, to save communities, and to save our next generation. I recognize that inaction is complicity, that inaction is turning our minds and our hearts away from our moral and human responsibility, and that when we have a platform to act, such as what is available to students and faculty in higher education, it is indeed a dereliction of duty to not do due diligence. As a scholar, I'm experiencing a paradox of responses. At one end of the spectrum, I'm energized to deploy my knowledge, my expertise, and research, as well as pedagogical tools to actively engage the silenced, to honor their strengths, and to de-emphasize deficits in our classrooms. Indeed, at the other end of the spectrum, I am exhausted because I do see the very long road ahead. I am, however, encouraged when I witness young people of all backgrounds standing shoulder to shoulder in the streets of numerous cities in the United States, in urban and rural areas, and in cities around the globe, speaking the refrain that Black Lives Matter. I'm encouraged by my colleagues who are working together to be self-reflective, engaging in humble inquiry, and engaging in active learning, trying to understand the root of racism. So though the road does seem long, it is a road that many people are willing to traverse together, and this gives me a moment to exhale and to breathe again. The second question that was posed to me was, how has 2020 shifted the nature of my research and my teaching? I have now added determined advocacy to my title of researcher and teacher. I have examined my own personal experiences and role in maintaining racism, especially in my teaching and my research. My teaching, I'm now very mindful of how I present information to my students in the classroom. Now, the images that I use represent different backgrounds. that the images are respectful and not presented from a deficit perspective, that I emphasize the fact that race is a social construct with no biological definition. Race does not explain health disparities and other differences among groups who present with different phenotypic characteristics. That I must name racism, including pointing out the bias in laws, policies, and practices that disenfranchise certain groups and place them at risk for gross inequities in many aspects of the society. Finally, I must choose teaching materials that uplift everyone in the classroom and not further oppress the already disenfranchised. For my research, I'm now more thoughtful about the questions that I ask and how I will engage communities in my scholarship. A final question posed to me was, what am I doing to create healing and repair? I am an advocate for diversity, equity, and inclusion, working with colleagues from UW Seattle and UW Bothell to educate other faculty in units across the tri-campus about how to incorporate inclusive and equitable teaching in their pedagogical practices. As a group, we put on a yearly teaching institute at the beginning of the school year to educate other faculty across the three campuses about how to make their curricula and teaching practices more inclusive, diverse, and ensure sensitivity to the various voices in the classrooms. This is our third year of the Institute, and I'm very proud of the work we have done in educating and providing strategies to faculty from the tri-campus to actively consider equity and social justice in their classrooms. This year, we have added anti-racism as a key element in our programming and work. And so our current objective is to support anti-racism, diversity, equity, and inclusion in the classrooms across the University of Washington. I'm currently working with colleagues at the University of Washington in Tacoma to implement strategies derived from a campus survey, a campus climate survey, an initiative put forth by all three campuses last academic year. We have received the findings from the survey, and our objective is to develop and implement strategies that will promote equity and a sense of belonging among all students, faculty, and staff at the University of Washington in Tacoma. I've also partnered with a colleague from the School of Nursing in Seattle to engage the general community in thoughtful discussions about the social determinants of health, and that racism is in fact a key component in understanding health outcomes. We are engaging in conversations using webinars, podcasts, and guest speaking events. Our desire is to continue to enforce the fact that racism is indeed a public health crisis and that we all have a role to play in dismantling it. Finally, as I indicated earlier in this lecture, I am recalibrating my teaching to make it more inclusive, and I'm currently working on how to adjust the execution of my research to make sure that it disrupts racism and elevates all participants. The absolute final question that was posed of me is, what can the University of Washington do? This is a difficult task and will not be achieved in one instance, in 1 year, in 10 years, or perhaps even my lifetime. What is important, though, is that we do begin the hard work now. We must name and therefore diagnose the problem, racism. Everyone must examine his or her personal and collective experiences and roles in maintaining racism. Everyone must be self-reflective, engage in humble inquiry, and engage in active learning. Once we have identified the enemy, that is racism, we are empowered to do something about it. The one thing that I've learned from my activities over the past few months is that the term racism is only uncomfortable because it has not been fully interrogated by most people. Individuals were not permitted to call its name. But we cannot just talk, we must also act. We must use the strategies and tools available to uplift all and not just some. It has been my pleasure spending time with you today. 2020 will indeed be remembered as a year of historic upheaval and change. It is also a year that presents us with many opportunities for repair, healing, and growth. We must seize this moment. Thank you so much. Take care.
Dr. Sharon Laing, thank you so much for your lecture. I found it just so deep and inspiring in many ways and relevant in so many ways. I'd like to start by asking you a question about how you got to where you are. You're an assistant professor in the School of Nursing, Healthcare, and Leadership at the University of Washington, Tacoma. And you're trained as a psychologist, as a clinical psychologist. Tell us how you got to where you are. Tell us how you became a psychologist and how you got to the School of Nursing, because your work cuts across disciplines in research, disciplines in fields of study. Tell us how you got here.
Well, thank you, Dr. Taylor, for this question. I very much appreciate this. So I did do I conducted my training in developmental psychology with an emphasis on health psychology at Howard University several moons ago. And when I decided to focus on health psychology towards the tail end of my doctoral study, I was very much interested in the 5-year survival rate for African American women from breast cancer. I started out doing psychophysiological research, looking at how we process information from the environment and how we address stress and how we can measure that using physiological responding. But then I was kind of connected with a colleague of mine in the Howard University Cancer Center, and I wasn't aware of the devastating impact of breast cancer on Black women at the time. And that kind of moved me to move in that domain. So I started my research in that area, and we did some community-based work looking at engagement in preventive care, that is engagement in mammogram and screening activity, and to kind of understand how can we assure that low-income communities have the opportunities that they need to maintain their yearly screening. Because the issue with Black women at the time was not that they were getting cancers more frequently than other groups. The issue was that they were more likely to be diagnosed with advanced stage cancer. And part of that issue was late diagnosis of the disease. And so from that work, I did some postdoctoral work at Rutgers in New Jersey. And then I came to UW Seattle, where I worked in the Health Promotion Research Center, to continue to do more work addressing health outcomes for low-resource communities. We were doing some work in rural communities like Mason County. But my final destination, which is in the School of Nursing and Healthcare Leadership, the reason why I targeted nursing was that I really wanted to work with public-facing individuals. Nurses are on the front lines, and they're the ones working directly with our community. And so if I, as a researcher, can empower nurses to really engage their communities, to really educate their communities sufficiently so that we can address health disparities, then I recognize that that is probably a better place for me than to be in a predominantly psychology department, just doing research off to the side. And so this is the reason why I targeted a School of Nursing and Healthcare Leadership. Thank you for that question.
Dr. Laing, you chose a powerful title, Dual Pandemics, Pathways to Healing and Repair. There's a lot in that title. Tell us why you chose that title.
Yes, certainly. And thank you again for that question. For the dual pandemics, of course, the obvious is the virus that we are dealing with. This is a very clear pandemic that we're dealing with. Unfortunately, and fortunately, because of course this pandemic allowed us to have both opportunities as well as challenges. This pandemic unearthed a number of different challenges that we are experiencing in our society right now.
These challenges include structural and systemic racism, health inequities that exist and have existed and continue to exist in our society, and of course, social and racial injustices. So there are a number of different pandemics that apparently became unearthed because of this viral pandemic that we experienced. Instead of the opportunities for repair, healing, and growth, of course, when we unearth something like racism and speak its name, which was quite difficult, I think, before for people to acknowledge that it remains a problem. By speaking its name, it gives us an opportunity to target it. By naming it, we can address and diagnose it. And once we diagnose something, then we can ultimately repair it. Now, once we repair racism, we will repair, hopefully, some of the structural inequities that exist in our society, as well as the health disparities. And then this leads to healing in terms of our entire community. And from the healing, we will grow. But I think that at this moment, we're still very stagnant because we were at a point where we were unwilling to name racism. And if we are unable to name and diagnose something, we are not able to heal.
Mm-hmm. You said several times in your talk, and I want to get this right, that there are no genotypical differences between us. In other words, that there are no substantive differences between me, an African-American male in Seattle, and a white male farmer living in Bozeman, Montana, that we're more similar than we are different. And you go on to say that race is a social construct. So is that true, that I am more similar than different than white farmer in Montana, genetically, but race is a social construct? Talk about that a little bit. How did we get to this point where our differences seem so great?
Absolutely, and thank you for that. Well, what's interesting, Dr. Taylor, is perhaps you and I are more different than you are different from a white male farmer in Montana, which is quite interesting. So in terms of gender, there may be substantially more differences than we are in terms of across race. Race is indeed a social construct. There is not a genetic factor that makes you different from your white male counterparts. Phenotypically, we look different, but unfortunately, we have used the phenotypic differences to characterize substantial differences between us that do not exist. We do not have biological differences between us across the different races. Race is a social construct. That is, it is a characterization that allows us to have a stratification across groups of people based on their phenotypic expression rather than anything substantial between us. And so by establishing differences, saying that substantial differences exist by race, then we can say that perhaps if we see differences in health outcomes across racial groups, there may be biological factors that might explain these differences, and these differences are not attributed to biological factors. We must speak about the fact that race is a social construct. And so racism affects health outcome, not race.
So what a powerful and profound thing to say then, because if I take that thought, then we've created many of the things that ail us so much, because in your talk, you say that residents of impoverished neighborhoods have a higher mortality rate, greater chronic health, and that racial and ethnic groups are more likely to experience poverty. So there's a doubling down on both poverty and race. And if I follow that line that the differences between us are not that great, we've created the conditions that have created so much suffering. These are human-created conditions.
Yes, absolutely. And that is the reason why in my talk, I really focus heavily on the social determinants of health, so that I can implicate the actual factor that is causing the devastation in terms of health outcome in communities. It is important for us to identify this. In our medical system, we spend a lot of time speaking about the biomedical model from the very beginning of the medical sciences. I think we've moved away from that to recognize that we cannot just focus on the biomedical sciences because on the biomedical entity, because then we focus on things like genetics and we lay bare or we eliminate the important pertinent role of the social factors, the contextual environment in which a person is navigating that determines our health outcome. Once we start to look at these social factors, not only can we remediate these social factors for everyone, but we can certainly improve the health of Americans and a lot of people around this world. But we must identify the true predictor of health outcome. It is not race, it is our social environment.
And so, speaking of the social environment, you described some of the things that make us so unhealthy in our social environment. What are some of the components? Help our students imagine and help our community imagine. What are some components of a healthy community that we all need and we all want that would actually help Black communities and impoverished communities? Imagine a little bit and talk a bit about what a vision of a healthy community looks like.
Well, I mean, one very clear, when I think about where I live right now, just having green space, lots of parks and recreation to go and walk about and to exercise. The one thing that I've seen during this pandemic is the fact that people are taking this opportunity now to go outside and to stretch their legs and to, do some exercise, go jogging and being able to breathe in clean air. Now think about an impoverished community whereby you do not have green space. You have a lot of buildings and a lot of construction happening. And so individuals are not able to go and walk peacefully in those environments. The air that they breathe, if there's a lot of pollution in that environment, if there's a lot of smog and a lot of toxic environmental substances in that environment, that is not healthful for anyone. When we think about the kind of foods and services, and whether we're talking about grocery stores in our community, you go into your grocery and you can buy fresh fruits and fresh vegetables and produce, and they're not costly. But then you may go into a low-income community and you may see a preponderance of these convenience stores or mini marts that house products that are not only processed, but they've been sitting on the shelves for many, many weeks. The one thing I'd like to say is that in one class that I teach that speaks to social determinants of health, I've had my students go into an impoverished neighborhood and just conduct a windshield survey just to see what's happening in those neighborhoods. And the one thing that they've come back to me and report is that when they go into the grocery stores of some of those impoverished neighborhoods, they may see fruits and vegetables, but they're old, they're brown, and they're more expensive than the other, like a Safeway or some other grocery store in another neighborhood. That's very sad that even when you try very hard to give your family the best that they can, the best fruits and vegetables, it's still much more expensive than if you were going into a middle class neighborhood. So of course the green space and the kind of food available and the fact that the housing is the construction of the housing is also important. These are key elements that makes for a very healthful community.
Dr. Laing, I have with me my own smartphone, which are, as you say, ubiquitous, but you see them as pretty powerful, which indeed they are, but you see them as powerful ways to monitor and track our brain, our heart, our muscles, our overall health. I want you to talk about the research you've done as a scholar with smartphones and health outcomes. But before you talk about that research, you did some work and research at Joint Lewis McChord, which is an Air Force base in Tacoma. Talk about that research, because I think that was a really important research and it's relevant now.
Yes, absolutely. So I did take a bit of time off and spend some time at Joint Base Lewis McChord in Tacoma. And I worked in the National Center for Telehealth and Technology. And so the center comprised of psychologists and technologists, and we're all there for one purpose: to develop tools that can support our guys in theater who are experiencing anxiety, depression, and other mental health concerns. Of course, we know that mental health concern is stigmatizing, but of course, it's more so for our guys on the battlefield. And so we were thinking about how best can we engage them in care in a way that is remote, that preserves their identity, and is not does not out them, so to speak. And so this is really very important work that we did for quite a while, and that they've done. And we developed different kinds of mobile apps to address health and wellness. Having spent some time there, I recognized that these tools can really be helpful in civilian population as well, because we do have the issue of healthcare access for low resource and disenfranchised community. And we knew that smartphones, they are ubiquitous. Why not access the tool that everyone uses to bring them back into healthcare? And so from there, I decided that why not explore the extent to which low resource communities are using their smartphones and willing to use it to support their health and wellness, and also explore how their primary care providers, those who are accessing community health centers, for instance, what are their thoughts about the likelihood of including data remotely into their current practices? Because this is an additional level that we are asking of them, to incorporate patients' remote data into their practices. So this exploratory study that we did was really to get a sense of the patient's willingness to use the device, as well as the healthcare provider's perceptions about how useful that information can be. So we conducted some research and found that almost 3/4 of low-income patients are willing to use their smartphones to support their health and wellness by obtaining information. Almost 50% of these patients are using mobile health apps to track their health outcomes, like caloric intake and step counts and blood pressure monitoring. We found that 60% of low-income patients are likely to use medical apps in order to address prescription refill or to locate a pharmacist. But what we did find, though, is that the lowest income of patients we're still not likely to use the device as well as we'd like. When we reviewed subsequent research on this, we learned that the lowest income patients are not able to go through the entire mobile health apps without support, meaning that a lot of them became frustrated as they work through the device because of the way the device is structured, the functionality, the ability to really understand the tool. And so what we recognize is that for these low-income communities, there are issues around digital literacy and health literacy. And if we're speaking about immigrant patients, there are issues around English proficiency as well. So then our conclusion in looking at these other research is the fact that these apps can make a difference, but the technologists who are working on these devices must tailor it specifically to the community so the uptake of the device is made easier by this community. There's a willingness, but we want to make sure that they can successfully use it to manage their health and wellness.
Racism, as you call out and describe, makes for bad policy, makes for bad school policy, public policy, community policy, leads to segregated schools and redlining in communities and divided communities. You talk about just the fact that racism is stressful on the human body. Talk about the impacts of racism physiologically, because it does horrible things to our bodies, the impact of racism.
Absolutely. Well, we know that stress, especially chronic stress, has a very profound impact on our bodies, right? So if we're looking at, say, the sympathetic nervous system, when we perceive a stressor, right, it activates certain areas in our brains that lead to the activation of a number of different structures within our body, especially the sympathetic nervous system. The sympathetic nervous system is designed to help us either flee from something that is threatening or fight something that is threatening. Imagine if that sympathetic nervous system remains on heightened alert over an extended period of time. That is, it's always activated. And if you are experiencing daily hassles, daily stressors, and even large stressors like racism, then you are constantly bombarding that sympathetic nervous system. And research, a number of different researchers, Dr. Norman Anderson, as well as David Williams, have found that as we continue to tap into that system, we see baseline levels of heart rate variability for African American men to be much higher than, say, white males or other males. Higher level of the baseline heart rate variability can then put an individual at risk for cardiovascular disease. So imagine experiencing racism, whether it's in the form of a microaggression or higher level, like being stopped by a police officer and not knowing what's going to happen next. Imagine experiencing that at a sustained level and what that does to the body system. Now, that's at the cardiovascular level. When we look at immune functioning, the same issue happens. When we are stressed or our body is at heightened alert, we have, of course, implicated cortisol, and cortisol is designed to protect us, right? To galvanize the system to address what's going on. But one of the impact of cortisol being elicited and activated is the fact that it is an inflammatory. So it lowers our body's immune response. So our body then is unable to deal with an attack from an outside invader, a foreign invader. And this is what they found with COVID-19, that in many ways, because of the experience of sustained stress for certain groups of people, their immune system has been compromised. If your immune system is compromised, you're more likely to contract any type of virus, particularly one as deadly as this. And this is not just discussion or talk. There's several research that has certainly borne this out, that for Black communities, we do have compromised immune functioning, and this is attributed to sustained stress.
2020 represents a bit of a paradox for you as a teacher and a scholar and as a person. You feel energized, you feel exhausted, and you feel encouraged, is what you said in your lecture. Talk about what it means to be energized, exhausted, and encouraged all at once.
Wow. Triple E, right? Energized. Energized. Energized because, Dr. Taylor, I recognize that we have a lot of work to do, and I'm so motivated to get out there and do this work. So I'm encouraged, quite encouraged, because when I looked at my television screen and I saw multiple races coming together and utter the refrain, Black Lives Matter, and fighting for justice for a race that has been disenfranchised, that was so encouraging to me. And even more encouraging was when I saw all the young people from multiple races joining arms, locking arms to fight this. So I am encouraged and I am energized, but yes, I will admit that I'm exhausted. It is exhausting when you think about the mountain that we have to climb, when you think about the impact on a community of people. And I'm a mother with children who have to address these issues. So I am exhausted, but I will end by saying that my exhaustion is perhaps mitigated by my energy and my sense of hope that we are now having the discussions that we must have. And from these discussions, we will heal, we will grow, and my gosh, I think we will repair. So yes.
Thank you so much, Dr. Laing. It was a beautiful ending. You give us reason to be hopeful. You give us reason to engage, and you give us reason to do the work of repair in our communities. Thank you so much.
Thank you, Dr. Taylor, for having me today. Thank you so much.